Welcome everyone to Project Firstline's Town Hall on the recent updates to CDC's Healthcare Infection Prevention and Control Guidance for COVID-19. I'm Liz McClune, lead for CDC's Project Firstline, and it's an absolute pleasure to have you here today. Before we get started, we want to welcome all of you and to thank you, not just for joining us, of course, but for the dedication you continue to show your patients and your colleagues in your community. It does not go unnoticed by any of us or unappreciated, and we really are grateful. We also recognize how valuable your time is, so we're going to go ahead and get started. As you know, last week, CDC made some updates to its healthcare infection prevention and control guidance for COVID-19. Today, we're going to walk you through those changes, explain why those changes were made, show you how to use the COVID-19 data tracker, which is the foundation for some of those recommendations. And last, but certainly not least, we want to answer questions from you. Many of you submitted questions during the registration process. Thank you for that. And we will get to some of those today, but you can also submit questions through the Zoom Q&A function found right at the bottom of your screen. Please note that to avoid confusion, we've disabled the chat function. So if you have a question, please submit it through the Q&A box. We are going to try and answer as many as we can at the end of the presentation. And now let's get to it. I'd like to introduce Dr. Alex Callan, Chief of the Prevention and Response Branch in the Division of Healthcare Quality Promotion here at CDC. Alex, take it away.
Great, thanks. And thanks to you all for joining. I'm going to take the next 15 minutes or so and highlight some of the changes to the healthcare infection prevention and control guidance that happened last week. Please, next slide. So really, the main thing that I want to highlight is that there were, although there were some changes that we will talk about, much of the changes were about kind of consolidating and making the guidance simpler to use. For those of you that have looked at our guidance, we had about 10 or 15 different guidance documents, which made it challenging to find some of the information that you needed. So this update has tried to streamline guidance by putting basically all of it into 3 different documents, which are highlighted here. The first is our what I'll call our general infection prevention and control guidance is called the interim infection prevention and control recommendations for healthcare personnel. That's basically the basics. It applies to all healthcare settings. Then the second is interim guidance for managing healthcare personnel with SARS-CoV-2 infection or exposure. That's kind of what we call our occupational health guidance and talks about things like return to work and exposures among healthcare personnel. And last but not least, the only remaining setting-specific guidance that will remain up is the nursing home guidance. This contains additional recommendations beyond what's in the general IPC guidance. So this is a good thing, I think, because it actually has helped us make it easier for you all to find our guidance and kind of simplified it, but it has required us to take down a lot of our setting-specific guidance, which I think is a good thing and a bad thing. Some of the highlights of the infection control guidance will be found, of the setting-specific guidance will be found in the first guidance in the last section. Next slide, please. So a bit of the rationale for why we have set healthcare-specific guidance and why we are updating it. So the first thing that I think you all recognize is that healthcare settings are and have been treated as kind of special during the whole pandemic. These, we see a lot of folks in these settings who are unable to avoid these settings. So if you're immunocompromised or at risk for severe outcomes, you may be able to not go to to a restaurant or the movie theater or whatever, but it's hard to avoid healthcare settings. In addition, there's lots of people who are sick in healthcare settings, including people with SARS-CoV-2. So we've tried to make our healthcare guidance more conservative than that we have seen for the community. And I think that leads to confusion sometimes. I mean, the perfect example of that was the mask guidance. I think, that came out, and I think you all saw, it was highlighted in the press that, CDC says if you're vaccinated, you don't need to wear a mask anymore for source control. And of course, that was true for the community, but not true for healthcare settings. And I think sometimes those messages get difficult to follow, and it is a little bit of a challenge. But please recognize that we tend to keep our guidance for healthcare settings more conservative. The other things that we wanted to try and do is make the guidance a little more evergreen and adaptable to both the specific situation that you're in and as things change. There's going to be variants that emerge that may have different impacts on the efficacy of the vaccine and transmissibility. not all your facilities are in the same situation. If you think back a few months ago, there were places that had a lot of transmission and places that had much less community transmission. And so we wanted to make our guidance adaptable to those different situations. And we also want to be able to provide higher level concepts rather than, try and adjudicate every single situation that could possibly come up in a healthcare setting, and give you all kind of the tools to be able to figure those things out without having to, have the specific recommendation written down in every instance, which I think you all recognize is very hard to do. And so you'll see as we go through this, some of the things that we've done to try and achieve these goals. Next slide, please. So the one thing I did want to highlight, which doesn't fit well into the changes thing, but I think is a common point of confusion, is our guidance with regard to immunocompromised folks. So, in general, we've said that people with moderate to severe immunocompromise, and by that I often mean folks who are, undergoing chemotherapy or transplant patients, et cetera, with very profound immune deficits, not, diabetics and people like that who have kind of subtler immune defects. We generally try to consider those folks as unvaccinated. So when we're tailoring our different recommendations to vaccinated and unvaccinated people, in general, I think it's a good rule of practice to put those people in the unvaccinated category, just to ensure a higher level of protection for those folks. Next slide, please. So let's jump into the changes. So the first thing I want to highlight is source control, because I think this is really something that is critically important, and because of the differences with the community, it's gotten somewhat confusing. So just to be clear, source control to us means use of a mask or a respirator or something over your nose and mouth to prevent the spread of respiratory secretions. And it does offer protection to the wearer, but more importantly, it probably offers protection to people around them. And we provide lots of options for source control in healthcare settings, including N95 respirators, masks, et cetera. Although cloth masks are probably fine for some situations, people who aren't working in patient care settings, patient-facing settings, et cetera, I think we generally try to avoid those in people who are taking care of patients just because they aren't PPE, they aren't personal protective equipment. And, it's hard, you never know for sure when you might be in a situation where PPE would be important. So in general, for people in taking care of patients in patient-facing places, we don't usually recommend the cloth mask for source control. Next slide, please. So again, just want to highlight, I said this a few times, in general, for everyone in the healthcare setting, we have always and continue to recommend a mask or some other source control device for those settings. There are a few exceptions, which we've tried to build in to address some of the issues I mentioned before about making it more adaptable. And these would apply to places which really no one is in, or very few people are in this point in the pandemic, with low to moderate community transmission. And you'll have some discussion about that towards the end, so you can figure out the area that you're in. But the people for whom source control might be considered not to use source control when we get to the place of having low to moderate community transmission are fully vaccinated healthcare personnel when they're in well-defined areas away from patients. So if you're a coder or a biller who doesn't interact with patients, or in a staff meeting room with just other staff, et cetera, fully vaccinated healthcare personnel could consider not using source control when we get to the point of being in areas with low to moderate community transmission. The same would apply for fully vaccinated patients and their visitors who are also fully vaccinated when they're visiting together alone in their room, and fully vaccinated residents in nursing homes. Again, this all applies to places with low to moderate community transmission. Next slide, please. The other thing that changed was some recommendations about quarantine for patients. So in an effort to kind of align this with what we have already recommended for healthcare personnel and also for consistency across settings, we no longer recommend quarantine for fully vaccinated patients who are close contacts. And this applies to the fully vaccinated and patients who are within 90 days of a SARS-CoV-2 infection. Of course, those folks would still be required to wear source control, and testing would still apply. So we can identify people who become positive as rapidly or become infected as rapidly as possible. So next slide, we can talk a little bit about the testing guidance. So there is a bit of confusion about the testing guidance too, but just to highlight, we do recommend testing for a number of situations which are outlined here. Probably most important is for symptomatic healthcare personnel and patients. And again, a very low threshold in this situation. We get called into a lot of outbreaks that start with a person who had fairly subtle symptoms that, were kind of ascribed to an allergy or something for a few days before anybody recognized it was SARS-CoV-2. So again, recommend a very low threshold for testing in that situation. Also, healthcare personnel with a higher risk exposure and patients with a close contact, we recommend testing, and we'll talk about the timing for that. For the determining who are healthcare personnel with a higher risk exposure, that second document I said, the occupational risk guidance can help you sort through that. We also recommend testing on units or facilities with outbreaks that may include people known with close contacts and those without. So if you're on a unit with an outbreak, we would recommend generally broad testing. The last category is expanded screening testing of healthcare personnel. This currently is required just for unvaccinated healthcare personnel in nursing homes, and basically is for people who are asymptomatic, not known to be close contacts, not in an outbreak, but just regular screening to detect asymptomatic cases. And again, that would be the setting where that is required for the CMS regulations, and also could be considered for other settings. Next slide, please. So what about the timing? So this changed a little bit, and it's been a source of confusion too, just because it varies slightly from the community guidance. For healthcare settings, which again, as I remind you, we tend to be a little bit more conservative. We recommend testing immediately, but generally not earlier than 2 days before exposure. So that's kind of the new piece there. I want to give people a chance to be detectable, to develop virus in their nose, et cetera. And then if negative, again, 5 to 7 days. So this differs a little bit from what's been recommended in the community for the reasons I mentioned. Next slide, please. So what about expanded screening for those of you working in nursing homes? So two kind of changes in that situation, and could be applicable if you're doing testing outside of nursing homes as well, as some people are. So first of all, we're now tying that to community transmission levels, which again, we'll hear about in a minute, instead of test positivity. So that'll be a little change there. We've also changed the frequency slightly. So if you're in an area with substantial to high community transmission, it's twice a week for these asymptomatic, non-exposed healthcare personnel. In your nursing homes in a moderate community transmission area, it's once a week. And then if you're in a low community transmission area, the good news is that asymptomatic non-exposed testing is no longer recommended. Next slide, please. So let's hit a couple infection control reminders here, just to remind you of things that still have not changed. So the first thing that hasn't changed is screening for healthcare personnel, patients, and visitors. Again, this doesn't necessarily have to be somebody sitting at the front door taking temperatures or asking the questions, but it does entail making sure that you have a way to be able to identify those people and triage them to the appropriate care. And there are additional examples provided in the updated guidance for what might be acceptable. The second is the managing of healthcare personnel with higher risk exposures, and the definition of higher risk exposures, again, would refer you to the guidance, the occupational health guidance was the second document I mentioned for that. And then last but not least, recs for PPE haven't changed. And again, there are kind of two pieces to that. The first is PPE for people with suspected or confirmed SARS-CoV-2 infection. We'll talk about that in a second. And then what we kind of call universal PPE. So I think many of you know, for areas with substantial to high transmission, we recommend the use of eye protection in addition to source control. A lot of people ask why that is, and the reason why is because the risk of it coming across somebody who's asymptomatic and infected is higher. You're protecting your mouth and nose, but you're not protecting your eyes. So the idea there is that would offer the healthcare worker some added protection. Next slide, please. So just a table to kind of summarize those recommendations. The far right column is the universal PPE, those without, that we don't know have suspected or confirmed SARS-CoV-2 infection. The middle column there for people who know or think have SARS-CoV-2 infection, and then the community transmission levels on the far left. So I think you'll see for all the columns of community transmission, the PPE for people with confirmed or suspected SARS-CoV-2 infection remains the same. Gown, gloves, eye protection, and an N95 or higher level respirator. For people who don't suspect or confirm to have SARS-CoV-2 infection, but you're in an area with high to substantial community transmission, source protection and source control and eye protection is recommended. That's the same as it's always been, and source control only for low to moderate settings. Next slide, please. So just another reminder about source control. I mentioned a couple of situations where source control might not be necessary in low to moderate transmission areas, regardless of community transmission. In fact, there is a couple situations though where we think source control should always be used, and I've highlighted those here. The first is obviously if you're not fully vaccinated. The second is if you have suspected or confirmed SARS-CoV infection, source control is critically important there. The third is if you had close contact or you're a healthcare personnel with a higher risk exposure, we recommend source control for the full 14 days, regardless of what the testing at day 2, let's say, and 5 to 7 days after exposure is. And then last but not least, if you're in a part of the facility that's having an outbreak testing is going on, we recommend everyone wear source control. Even if you meet one of those exceptions, we recommend it for people with moderate to severe immunocompromised, and we also recommend it if public health authorities have in your jurisdiction have different rules. And last slide, last but not least, everybody can certainly next slide, please. Sorry. Everybody can sure go ahead and use source control. It's a great practice, even if you're fully vaccinated. And that is probably particularly important for people who have someone in their household who's either immunocompromised or an increased risk of disease or unvaccinated. So apologies, that was super quick, but hopefully I've given you an idea of where you can look to find the answers to your question now that the guidance has been kind of streamlined, and hopefully give you some food for thought for questions. So let me turn it back over to Liz or Dr. Carlson.
Thank you, Alex, so much. And now we recognize, of course, as we said at the top of the call, and as you saw throughout the presentation just now, that a lot of these recommendations are tied to level of COVID-19 transmission in the community. And so that uses our CDC COVID-19 data tracker. And so I'm going to turn it over to Dr. Abigail Carlson, an infectious disease doctor here with us at Project Firstline, to walk you through how to find that tracker, how to use it, and what it means for you. Abby?
All right, hello everyone. Sorry, I'm just going to flip the slides forward. So like we've been saying, some of these new recommendations are attached to the level of community transmission in your county where your healthcare facility is located. And determining that, we're going to go through, as Liz said, and show you exactly where to find that information so that you can choose the recommendations that are suited for your particular situation. So give me one moment. I'm going to switch my screen here. All right. I'm going to actually go back to our main page. So starting from here, you can Google search always for the CDC COVID-19 data tracker, and you will get to our data page usually through the search engines. But if you are coming in from our main page, you go into Coronavirus Disease 2019 and click here in the top tabs on cases and data. And that, if you click right on there, you'll come right to our COVID-19 data tracker. And the COVID data tracker has a ton of information, but what we are interested in is here on the right-hand side, the community transmission in the United States. Now, I will say, if you are not in the 50 United States or Puerto Rico or the District of Columbia, you will want to use the state level community transmission tracker and click on your territory to get local information. But for everyone else, you're going to go to the community transmission and county level community transmission page. So you can either click here on this link, or my preferred shortcut is just to go up to this community transmission bar right at the top and click on it. You will get to this page, which is the COVID-19 Integrated County Viewer. I highly suggest bookmarking this page for your reference once you've made it here. And I think we are going to try to provide a link as well in the chat so that you have it. Here in the drop-down menu, you should choose your state or territory where you are. We will go to where the CDC is here in Georgia, and then it will bring up a list of county or metro areas, and we are in DeKalb County. And when you get that entered, you will get a page that looks like this with your county highlighted, and you'll see here that it says community transmission and then gives you the level of transmission. The 4 levels, as you've seen, are high, substantial, moderate, and low. If you want to know more about how community transmission is calculated by the CDC, that information is here, and you're welcome to dig into those numbers a little bit more. And it is updated every day by 8 p.m. Eastern time. So this is a daily changing map. So don't hesitate to look in each day and see where you are. Once you've determined this level, that is the level that you will use to decide what your appropriate infection prevention guidance will be based on your transmission level. So I'm gonna come back here to our presentation. And I just want to run again through a quick summary of everything that Dr. Kellen has said based on community transmission levels. And these, again, are general rules that apply in most situations. There are exceptions for many of these, which you will find more detailed guidance in the links to the main guidance. But if your community transmission is high or substantial, for source control, people should be wearing their mask or their other source control, their respirator, et cetera, regardless of vaccination status at all times, okay? And in all areas of the healthcare setting. We also recommend that they're wearing eye protection in addition to their mask when they're caring for patients without confirmed or suspected SARS-CoV-2. So when you're with patients, we recommend adding eye protection to mask. In nursing homes, unvaccinated personnel should be getting viral testing at least twice a week. And in general, residents should be wearing masks in all communal spaces. Once you get to moderate transmission, we recommend that fully vaccinated healthcare personnel may take off their mask or other source control when they're in staff-only areas. You do not need to wear eye protection when caring for patients without confirmed or suspected SARS-CoV-2 infection, unless, of course, there's another indication for it. And then in nursing homes, the unvaccinated healthcare personnel, the testing frequency goes down to once a week, and vaccinated residents may take off masks in communal spaces, again, if there's no other indication for them to have a mask in those spaces. And finally, for low community transmission, here the source control guidance for vaccinated personnel remains the same. You can take off your mask if you so desire and have no other indication for masking if you're in staff-only areas. You do not need to wear eye protection with patients unless there's another indication for it. And then the change here is mostly that the expanded screening of unvaccinated personnel is not recommended at low community transmission. Residents may still take off their masks unless they have another indication to have them on. And with that, I will turn it back to Liz for our question session.
Thank you, Abby. So again, we were lucky enough and grateful enough to get some questions ahead of time from you all during the registration process. So we're going to go through a few of those now and then answer some of the ones we're getting through live. And thank you guys for asking fantastic questions. And we'll keep going. All right, the first question is, if I'm fully vaccinated and an exposure happens, what are the guidelines? What about if the exposure is a family member?
Yeah, thanks, Liz. This is Melissa. I work with Alex and David on the healthcare infection control team, so I'll take that question. So the answer to that question is addressed in the second guidance that Dr. Callan mentioned, the occupational health guidance. But I'm going to walk through some highlights here. So I think first and foremost, any decisions about work restriction or risk assessment should be made in consultation with your occupational health program or whoever is designated in that role for your healthcare facility. They really are best positioned to assess your individual situation, what happened, the risk, and when work restriction is warranted. In addition, they would be the ones to help connect you to testing, since testing is recommended following higher risk exposures. So Let me talk a little bit about higher risk exposures. So we talk about that in the guidance, and in general, higher risk exposures involve healthcare personnel exposure of their eyes, nose or mouth to potentially material that potentially contains SARS-CoV-2, particularly if they were present during an aerosol generating procedure, like say an intubation of a patient. And so we give some examples of missing PPE components during close contact exposures with patients in that guidance in the first row that would constitute a higher risk exposure. Now, that may not be all encompassing of higher risk exposures. There are other exposures that we classify as lower risk, but they still may impart some risk. And so again, that is why kind of consultation with your occupational health program can help make some of those determinations. So say that you have a higher risk exposure as determined in this guidance or with occupational health. So in simplistic purposes, if you are not fully vaccinated and you have one of these higher risk exposures, we recommend the testing that Dr. Callan talked about. And we recommend additionally that you be excluded from work for 14 days following that exposure. And that you continue to monitor yourself for symptoms and all of those things. If you are fully vaccinated and you've had a higher risk exposure, we also still recommend testing in that situation. We recommend that you continue to wear source control for the 14 days following your exposure. And as Dr. Callan pointed out, really at all times in healthcare, even regardless of that exposure, and that you monitor yourself for symptoms. But you wouldn't necessarily have to be excluded from work if you didn't have other reasons for us to think that you could be at risk, such as that the vaccine may not be as effective, such as if you were moderate to severely immunocompromised, and we give some considerations in the guidance. So again, if you were fully vaccinated and had one of those higher risk exposures, if approved by your occupational health program per the CDC guidance, you could continue to work, but should be excluded if you develop symptoms or if you're tested and you're positive for SARS-CoV-2 infection. So that's kind of an overview. Now let's talk, those are assuming that you essentially have a discrete single exposure. We know when it happened and we can kind of follow you forward. So what about if you have exposures that are ongoing, such as you are living with someone in your home that has SARS-CoV-2 infection? As you know, we say that if that's happening, you should do whatever you can to isolate that individual and avoid contact with them, but let's assume that you can't. So the same parallels hold true here. If you are not fully vaccinated, we would recommend work exclusion. And we would recommend work exclusion continuing through the 14 days after your last exposure when your loved one or your family member was infectious. So if someone has SARS-CoV-2 and is otherwise healthy, we recommend that they be isolated for 10 days after their symptom onset or their diagnosis. So essentially, we would be recommending work exclusion for 14 days after they're no longer infectious. If you are fully vaccinated, you don't necessarily have to be excluded from work, again, assuming that your testing is negative and you don't have symptoms. But again, that is something that you really should be talking about with the occupational health program. And you can see that we talk a little bit about travel and community exposures in the last or third row of the table in that guidance. So I'm going to stop here. I know I've said a lot, and David and Alex, please chime in if you have anything to add to that.
Thanks, Melissa. That was really helpful. Next question, please. Okay. When should a healthcare worker wear an N95? Should it be only with confirmed hospitalized COVID patients?
So, hey, this is David Kuhar, and I work with Alex and Melissa, and I will take this question. So, in general, N95 respirators are worn when they are recommended for when caring for someone who you suspect or know have a certain disease. And typically, historically, this has been diseases like tuberculosis, varicella, measles. But N95 use is also recommended as a part of the personal protective equipment that should be used with people who you know have SARS-CoV-2 infection or who you suspect has SARS-CoV-2 infection. And so one important distinction, you should be wearing that N95 along with all of the other recommended personal protective equipment, a gown, gloves, and eye protection when you suspect they could have it or when you know they could have it. However, there are two other instances where we also recommend N95 use during the pandemic. First, beyond the SARS-CoV-2 care, in areas where there is substantial or high community transmission of SARS-CoV-2, an N95 respirator should be used for all aerosol generating procedures done on patients or residents. This is regardless of whether you suspect that they could or suspect that they even might have SARS-CoV-2 infection. Because there's a lot circulating of SARS-CoV-2 circulating in the community, we want all healthcare personnel to wear an N95 respirator during those procedures. Also, all surgical procedures at times when there's substantial to high community transmission. And we even have a statement that during that time, facilities can consider recommending use of N95s in other situations where there might be increased risk for potential transmission, such as working in an area where there may be poor ventilation for extended periods of time with other patients, et cetera. So that's another situation in the pandemic where an N95 is recommended. And then lastly, an N95 can also be used, or it's an option to be used for source control. And this is the last area where it is. And for source control, there are several options that can be used. And we indicate that in the guidance, and it's in that first guidance that Alex mentioned, which is the interim infection prevention and control recs for healthcare personnel during the pandemic. And for source include a NIOSH approved N95 or equivalent or higher level respirator, a respirator that's approved under standards used in other countries, as well as a well-fitting face mask. And so I think that pretty much sums it up. I know I've said a lot, but those are pretty much the three major situations where an N95 is recommended for use in healthcare, specifically with regards to SARS-CoV-2 in the pandemic.
Thank you so much. And there's kind of a follow-up to that on the next slide. If an N95 is being used for source control only, does it have to be fit tested? Does it need to be seal checked? And when do you discard it?
All right, well, this is David Kuhar, and I will take this one as well because it follows what I was just saying. So there is an important distinction in using an N95 respirator for source control versus for protection, say for SARS-CoV-2 care. When you're using a respirator when it's recommended for patient care, if you suspect or you know that they have SARS-CoV-2, the expectation, and this is an OSHA requirement, is that you are using that respirator in the context of what they call a respiratory protection program. And that as a part of that, you've been medically cleared, trained, and fit tested to use that respirator. And the point of the fit test is that it ensures that the respirator is fitting correctly and that it is seated correctly on your face so that when you breathe in, the air is going through the filter rather than being pulled around the sides of the respirator and not being filtered. So it really ensures that that fit is correct because the fit is needed to ensure that it's doing its job, filtering what you breathe. When you use a respirator for source control only, OSHA has issued actually an emergency temporary standard that allows employers to provide people a respirator to use when a respirator is not necessarily needed for their protection. And source control probably fits in this category, if you will. And so when that's the case, OSHA allows there to not necessarily be fit testing, but the expectation is still that the employer teaches you how to use it and that you're able to do what they call a seal check, a seal check to see if you're getting an appropriate fit. And the seal checks and how to do them actually depend on the model of respirator that you have and you've been issued. And so the manufacturer in their package insert is supposed to indicate how that's done. Oh, and then I'm sorry, I almost forgot the last part, when to discard a respirator if you're using it for source control. Essentially, whenever the respirator becomes damaged or soiled, you would want to take it off, discard it, and replace it. In addition, any other time that you remove the respirator, We are not in a period of shortages here, so the expectation is that anytime you take off a respirator, you can discard it and get a fresh one to continue to use for source control after. And that should cover it, Liz.
Thank you so much. And for those of you who are interested in some more information about that self-sealed check, if you go to our Project Firstline website, or we'll be putting a link directly to it in the chat, you can see a video of how to do that self-sealed check correctly. And now for our live questions, I'm going to turn it back to Dr. Callan. Alex?
Great, thanks. So we have about 5 minutes, so this is going to enter the lightning round here. So David and Melissa, if you guys could just answer briefly so we can get as many questions as possible. First question is about, David, maybe you could weigh in. There's lots of questions about the characteristics that should be in place for safe eye protection. Are safety glasses okay, et cetera? Do you want to comment on that?
Yeah, this is David. So quickly, in the guidance, we pretty much mentioned just goggles and face shields. However, there are absolutely groups that use safety glasses, and we know this. It's pretty common in EMS, et cetera. The idea and why we say goggles or face shields, it's really just about coverage. Goggles provide a lot of coverage and fully cover your eyes. Face shields tend to do the same thing, and these are well standardized. Safety glasses, there's a lot more wiggle room in how these are designed and how they fit. So we, in general, we have not called them out as appropriate eye protection for COVID care, but because there is so much variability in their design and that they just might not cover the eyes as much as the other devices. So goggles or face shields, what remain recommended.
Great, thanks, David. Melissa, here's one for you. What is the proper isolation and quarantine time, and when does it start for COVID-19? So I assume they mean not exposed, well, either exposed patient or infected.
Yeah, so let me just, I know we're trying to go fast, but let me unpack that a little bit. So isolation is what is recommended for someone that has SARS-CoV-2 infection or symptoms, and we suspect they have SARS-CoV-2 infection. So the specifics of that are outlined in our main IPC guidance under the section that addresses duration of transmission-based precautions. And in general, for someone who is not severely immunocompromised and doesn't have severe illness, it's essentially recommended for about 10 days, assuming that they have been afebrile for at least 24 hours and their symptoms are improving. That period may be longer if they are severely immunocompromised or if they are severely ill. And we explain that in a lot more detail in the guidance, so please do look there. Quarantine is what is recommended for someone who has been exposed to someone with SARS-CoV-2 infection, right? And so in general, for those that are not vaccinated, that are not fully vaccinated and have close contact or higher risk exposure, we recommend quarantine for 14 days following that exposure. Again, assuming that it is a discrete one-time exposure and you know when it happened. We also recommend they continue to use source control and the testing that Dr. Callan outlined in that situation. And then, as I mentioned, even if you are fully vaccinated, there may be some circumstances when quarantine is also recommended if you're exposed. But in general, we don't have a recommendation to quarantine after exposure if you are fully vaccinated. Let me turn it back to you, Dr. Callan.
Thanks so much. And then a couple questions here, Melissa, that you might get answered. Some confusion about the testing immediately and then 5 to 7 days versus the every 3 days during until no cases for 14 days in an outbreak. Do you want to just comment on that?
Yeah, so for those people that we actually know have met the definition for a close contact or a higher risk exposure, we recommend that first testing, and we say immediately if you don't kind of know when the exposure happened, you find out about it and you find that person a couple days later, which is what happens a lot of the time. But if you know, like, I'm exposed at this exact minute, testing me at this exact minute, I'm not going to be positive following, seconds after an exposure, right? So that's why we recommend not earlier than 2 days after the exposure. And then if negative, again, 5 to 7 days. And that's based on modeling, looking about from exposure, the period when you're most likely to see people become infected. But as you know, people, although smaller numbers, can be infected after those points in time, which is why we continue to recommend the 14-day quarantine. So that's when you know what the exposure is. In an outbreak situation, particularly if you're in a situation where you're doing facility-wide testing, right? You may not be able to identify all the close contacts. They could be exposed, but you're not sure. And so you are doing serial testing. And if you are continuing to find people that are popping up positive, that could very well be because there is an ongoing exposure that you haven't mitigated with your infection control interventions. And that is why we recommend continuing to do concentric testing until 14 days out from exposure. But if it's a discrete exposure that you know what happened and it's not continuing to happen, that is why we have the immediate and 5 to 7 days later. Let me stop there and feel free to add anything, Alex, or move to the next.
No, we're running low on time, but I did want to highlight a couple of things before I turn it back over to Liz. I mean, again, please do remember when we're talking about the PPE for SARS-CoV-2 that we are talking about, that's in addition to any PPE we're using already. So for standard precautions and transmission-based precautions, I think sometimes that gets skipped over, but please do keep that in mind. And then I think there was some question that David kind of commented a little bit about the use of extended use for N95s and face masks and things like that. So wearing it for more than one patient, not removing it and putting it back on, but wearing it continually. And do recognize that when you're using it for PPE, with the current supplies in most places, the usual rules would apply where you should probably don and doff that between each patient. But we do have an allowance for extended use, again, wearing it again for the same multiple patients for both face mask and N95 when used for source control. To use extended use. So that is another kind of a little bit of change that I thought of as we we're talking about this. So I think, unfortunately, we're at time, so let me turn it back over to Liz.
Thanks, Alex. I wish we had more time, but I'm so grateful to you and to Abby, David, Melissa for joining us today, for all of the work that you're doing as well. But also thank you all for joining us today. We wanted to make sure before we close that you had links to the Project Firstline resources. We talk infection control all the time. In addition, a recording of this will be posted to that website, and we'll let you know when it does, in addition to the slides. And with that, I want to close and thank you all for joining us, for your incredible questions. I think they helped you and your colleagues, and we can't wait to see you soon. Thanks. Have a good one.